Hello, everybody. Welcome back to the Little Brain Campaign. I am your host, Dr. Lauren LaRose. I'm a board certified child and adolescent psychiatrist and adult psychiatrist with a private practice in Metairie, Louisiana. And in this podcast, I like to talk to different experts from various fields related to mental health and physical health of kids and their caregivers. So today I am here with Dr. Courtney Lewis. She is a therapist in town. We've shared a lot of patients, and we're going to dig in on something that has recently come up in my own home, which is OCD. So just to give a little background on that, for people who may be new to the podcast, I have a child who has a condition called PANS, pediatric acute onset neuropsychiatric syndrome. And part of that condition is OCD. So his presentation was not aligned with what I learned in my training about OCD. And so I've had to do a lot of learning on my own about it. And I'm trying to pick it up more in my patient population. So, Dr. Lewis, thank you for being
Of
here.
course.
Tell us a little bit about what you do, and then I want to hear about how did you get to where you are now in your career?
Yeah, so I've been in private practice in New Orleans for about 10 years. I landed in New Orleans for my internship, and I thought I'd be here a year, and that was 17 years ago. So, yeah, I have a private practice. I only see children and adolescents. I'm kind of unique as
Hmm.
a psychologist in private practice in that I only do therapy.
Uh-huh.
A lot of my peers tend to focus on evaluations.
Yep.
And I have a couple of little specialty areas, but one of those is OCD. So a lot of the referrals I
Hmm.
get from pediatricians and psychiatrists like yourself are for OCD.
And how did you get into that? How did you get into that niche?
I went to graduate school at the University of Florida, and as life has it, you kind of learn what's there. But they had a
Hmm.
big research arm for OCD and an OCD clinic. Um, and they also, which was really impactful, had an intensive OCD program where people would travel from all over the country and come for 2 or 3 weeks. And
Wow.
so,
Uh-huh.
as graduate students, that's what they funneled us into that.
Yeah. Okay. So explain to us, for people who may not really understand, I think we all hear about
Sure,
OCD,
sure, sure.
but explain to us, what is it?
Yeah, I think it's a term that people use just as an adjective. um,
Mm-hmm. Mm-hmm.
like I had such an OCD day, or like this is my OCD, and it's usually not accurate. But if you just
Yep.
break down the term, it's obsessive compulsive disorder. And
Mm-hmm.
so we would define an obsession as an unwanted or intrusive thought, a thought that's
Mm-hmm.
recurring, meaning it happens a lot,
Mm-hmm.
a thought that you don't want to be there, and a thought
Right.
or an image that causes a lot of distress.
Mm-hmm.
A lot of times with kids, I call them like sticky thoughts. They just won't go
Yep.
away. And because
Mm-hmm.
it makes you feel so horrible, you want to get rid of it. And
Mm-hmm.
that's where the compulsion comes in. So a compulsion is anything one does to relieve, to comfort the distress associated with the obsession. So it might be
Yep.
something you do, and it could be something you observe someone do. It could be something you
Mm-hmm.
do in your brain, or it could be
Mm-hmm.
something you avoid.
Okay.
So you have to have obsessions, you have to have compulsions, and they have to cause impairment.
Mm-hmm.
And we all have quirks and little things we might like a certain way, but you don't really land
Right.
in an office like myself until it's causing a problem in your life.
Right.
Um, and part of how they define that is that the symptoms have to take up at least an hour a day, which is a bit
Okay.
arbitrary, but that's just reflecting the fact that um, it should be taking up a lot of space in your life and getting in the way
Right.
of what a kid or a family wants to do or needs to do.
Right. Right. Okay.
It's the bird's eye view.
So, I think what's tricky is that we have these images of what OCD is, probably from movies,
Sure, sure.
and we know generally that's like a representation in an adult. Okay.
Uh-huh.
And it's usually very focused on the compulsive behaviors because that's what you can observe, from the outside,
Correct.
right?
Correct.
And what's hard with kids, I have found, is that if there's no overt compulsions, or if the compulsions are kind of sneaky and you don't really
Sneaky.
recognize them as compulsions, right?
Right.
A lot of kids are not able, if because of their age or their developmental stage, they may not be able to actually verbalize the obsessive thoughts that they're having.
Correct.
Um, and that's something we noticed with our son is, until he got to a certain age and the therapist was really able to pick apart the thoughts and tell us like these are the obsessive thoughts he was having, then it was like, whoa, oh my gosh, we had no idea that that was going on.
Yeah, that I think is the art of it, is that particularly in young children, it's like you said, I mean, developmentally, they don't have the language skills yet to describe what they're experiencing in their mind. I mean, that's hard for
Yep.
adults.
Yep.
Um, and I think sneaky is a word I use all the time because a lot of
Hmm.
compulsions for children and teenagers can be normative until they're not.
Right.
So,
Right.
for an example, that'd be a good place to go. One of the most common
Okay.
childhood compulsions is reassurance seeking.
Yes. Hmm.
So we could spend like 2 hours on that, but I mean, it's a very
Yep.
normal thing for a child to seek reassurance from their parent. And then it's
Right.
very healthy for a parent to reassure their child. This is part of what we do in
Right.
raising our children. But when you jump into OCDville, all of a sudden reassurance
Hmm.
can be a compulsion. And so that might be
Yep.
a child saying, like, sometimes children will get very fixated on if they've made a mistake or if they're a
Uh-huh.
good or a bad person, um,
Hmm.
or if a food is okay to eat. And
Yep.
so they might say to their mom, like, is this food expired? And mom doesn't really notice because maybe a kid
Hmm.
will say that. But then you start noticing the kid won't eat unless the parent tells them 3, 4, 5 times, checks, double
Yep.
checks, checks again. So, um, yeah, reassurance seeking, would say is the most common and really tricky to. It takes a while for parents to see that it's happening.
Yep. Yep. Okay. And so tell us, I think what you're getting to is what we call like accommodation, right? Where
Hmm.
the parent unknowingly becomes part of this like obsessive compulsive pattern.
Always.
Um, yeah. So talk a little bit more about that and like what you see in families and what is the solution for that?
Sure. I mean, I think to back up a little bit is that we know from a research perspective, and certainly my clinical experience has reflected that is families have to be involved in treatment, or it's not
Yeah.
going to work.
Yep.
And I would even argue when you have an adult, their treatment benefits from their support system being involved.
Yep.
Um, but and this is very hard, I think, for parents to internalize or cope with because it's painful. Every child I've
Hmm.
ever seen with OCD, their parents are wrapped up in their compulsions. That's the
Yep.
nature of it because the parent
Yep.
is designed to be the protector to take care of the
Hmm.
child. So in
Hmm.
order for kids to get better, um, parents have to be in treatment. And
Yeah.
that could be new for parents because sometimes parents think like they're going to drop their kid off at therapy. So
Hmm.
takes a while to be like,
Nope.
no, this is going to be the hardest on you.
Yep.
Um,
Yep.
in terms of the accommodation, I mean, I think it might be helpful if I explain the exposure and response prevention
Yeah. Yeah.
piece.
Go ahead.
Okay.
Uh-huh. Yep.
So, like, if you're Googling and you're like, I think my kid has OCD, what kind of therapy do I need? One phrase you're looking
Hmm.
for is exposure and response prevention. And what
Okay.
that means is that we expose ourselves to the thing that is feared, the thing that makes us
Hmm.
uncomfortable, and we quite literally prevent the response.
Okay.
So, when children present to treatment, often they are engaged in some kind of compulsive behavior that requires the parent's participation.
Right.
Um, so, a very common example would be school avoidance. There's
Okay.
something about going to school that is fearful. I can't go to school because this particular thing will happen. And the parent then is the one who's either going to drive the kid to school
Mhm.
or let them stay home, right?
Uh-huh.
And
Yep.
so, if we're going to prevent the response, which is the staying home from school, we have to work with the parents not to accommodate that behavior.
Yeah. Yeah.
Another example, this one's like much more specific, and this comes up a lot. There's a lot of OCD that happens in the bathroom.
Really?
So,
Okay.
something that I've come across a lot is kids will say, um, am I clean? Like if they've had a bowel
Uh-huh.
movement, they're like, am I clean? Now,
Mhm.
we all know if your kid is 3, it's probably good to help wipe them because
Right.
they can't get themselves clean. But if you have like a 6-year-old or an 8-year-old and they're like, mommy, come
Mhm.
wipe me, come check me. Am I clean? Am I clean? Do it again, do it again, do it again. I don't think I'm clean, right?
Mhm.
The parent is accommodating that by wiping them and by providing that reassurance. So we have to
Okay.
work with the
Huh.
parent to disengage from that so that the
Yeah.
child can learn to sit with their discomfort, sit with their distress, and learn that without the compulsion, their feelings that are hard, like that have risen, can get better on their own. So their brain and
Right.
body, by the time they get to my office, have learned the only way to feel better is if I avoid, or I engage in a compulsion.
Yeah.
And through
Yeah.
therapy, we're teaching them you actually can feel better. These feelings can go away, even if the compulsion or the avoidance doesn't occur.
This is so like I feel like during some of these episodes, I'm like learning things and I'm like, "Oh my gosh, this patient, this is exactly what's
Yes.
going on."
Yeah, yeah,
I had
yeah.
never I had
Mhm.
never really like I definitely have seen that like the bathroom stuff and then the school avoidance. Like I'd never really thought of that as potentially like an OCD kind of issue. And now I'm thinking of all these kids that have that school avoidance and I'm
Right.
like,
I
I
mean,
need to
school
rethink this.
avoidance is such a broad topic. So I certainly don't want to
It is.
suggest it's always that, but I've had plenty of
Yeah,
school
yeah.
avoidance that gets down to that.
Yeah, yeah. Well, and it takes on a very like obsessive compulsive pattern, you know?
For sure.
That is
Right.
super interesting.
Yeah. School
Very
avoidance is
interesting.
really, really hard. I don't wish that upon
I
anyone.
know. Do we know like how because I always have parents ask me this, like, how did my kid get this way? Like as far as OCD goes, like do we this is something that's hardwired, it's inherited? What do we know like as far as the research goes?
I mean, there's a lot of evidence that there's a genetic component to it. Um,
Mhm.
Something that's really interesting and I think will look different in 20 years is that when
Yep.
parents come in, they're like, I'm struggling with this with my child. And then 2, maybe 3 sessions in, because I provide a lot of education about what OCD is. I mean, that's so
Yep.
important. It's just for them to understand. You'll get this look, I can see it in their eye, and they're like, I've had OCD my life.
Yep.
You know?
Yep.
And it's like they didn't
Uh-huh.
even know it. They didn't even
Yep.
know it. So,
Mhm.
yes, I think there's a genetic, not I think, the research has shown there is a genetic component. I mean, that's kind of like a
Yep.
vague thing to say, though. I mean, we can say that about a lot of things. There's often
Yeah.
a
Yeah.
trigger. I think about it
Mhm.
almost like a seed under the ground, and sometimes something will
Mhm.
water it and it will kind of blossom.
Yep.
Um, so that often in terms of onset, of course, I know you've done a lot of teaching around pans and pandas.
Yeah.
You can have a
Yep.
like a physiological presentation that kind of kicks off this pattern.
Yep.
Um, and that's pretty interesting because it comes out of nowhere, but then it
Mhm.
can take on a life of its own,
Yes.
which
Yep.
is which is why what research and clinical practice have taught us is that even if it's a PANS or PANDAS presentation, families benefit from treatment.
100%. They still need the therapy.
Yeah,
Yep. They still need the therapy. Yeah, because it does I mean, OCD by nature, I feel like can just spiral so out of control
yeah,
that you're right. Like it doesn't always matter. I mean, it does matter where it came from because like if it's pans and pandas, like you do have to treat inflammation and all those kind of things.
correct.
But the OCD can persist beyond just treating the inflammation
Mhm.
and the initial infection.
Right. It can be quite
Um,
insidious into general family functioning. And sometimes
yep,
families come to me because they are in distress and they are aware something's not okay. But sometimes families, through treatment, realize like, whoa, this really has been driving our ship. Our whole family
yeah,
has been really controlled by this. And
yep,
it can be quite devastating. I think we see
yeah.
cutesy examples often, um,
Hmm.
but it really can, it causes a lot of suffering.
Are there some good, like, just so that people know, kind of like different presentations of OCD in kids that maybe are not familiar to the general public? Like, are there some good case examples that you can give us?
Sure. I mean, that's always fun and could go on for a long time. Um, okay, so one that's interesting, so something we teach families is OCD is not logical. I mean,
Hmm.
and so a lot of times you'll hear these things and you're like, that doesn't make any sense. And that's kind of more evidence that it might be OCD.
Yep.
So, one of the things can happen is some weird things between parent and child. So I've had children who fear that their parent might hurt them. This is often
Hmm.
around food. Like, did my
Okay.
mom poison the food? Did my
Hmm.
dad contaminate the food? Um,
Yep.
and that's really confusing for everyone involved and really upsetting. I mean, one of the basic ways we nurture our kids is feeding them. And so the way that
Hmm.
will look like is they start refusing food from a parent, or they demand that they observe the parent prepare the food, or they
Hmm.
only accept a prepackaged food that they open themselves. Um,
Hmm.
so there's a lot of themes around harm. That would be fear of being harmed by someone else.
Hmm.
Um, and very another very common theme is, am I going to harm either
Okay.
myself or other people? And that
Hmm.
often can take a while to come out in therapy because it can be quite embarrassing. And
Yeah.
people can have a lot of shame around that. Because when you're having these thoughts, it's not just a thought. There's usually some pretty graphic images that can go around that.
Yep.
So, for
Yep.
example, am I going to stab someone with a knife? And so I quit going in the kitchen. Now, all mom or
Yeah.
dad sees is they won't go in the kitchen anymore, right?
Hmm.
But the kid is really, really concerned that they might hurt. And so they are avoiding sharp objects. Or the parent
Yep.
might say, like, they always have their hands in their pocket, right? And it's because they
Hmm.
don't want to
Hmm.
hurt anyone with their hands. Um,
That's so interesting.
or they're in a setting where there's maybe other sharp things. And so this can get confusing at school. For example, like science lab, you're going to dissect the frog and you have the
Hmm.
little, I
Uh-huh.
can't go to school today, or I
Hmm.
refuse to participate, which might be
Hmm.
perceived as defiant or just
Yep.
generally like an anxious kiddo. Um, but then that can really, really snowball where I've seen kids like the knife feels kind of obvious, right? Like we're like, okay, a knife, self harm. But then I've had
Right.
kids who are like, I can't walk through that doorway. What if I accidentally run into someone and I shove them in the doorway? Or what if
Oh,
my
wow.
wrist hits that, like, the little metal piece where the door clicks in?
Yeah.
What if my
Yeah.
wrist
Uh-huh.
hits that and I hurt myself? Um,
Wow.
so harm is a very, very big theme.
Uh-huh.
Um, and it's hard to talk about. It's scary to people. Um,
Yeah.
I think it gets very confused often in mental health offices because,
Yes.
if you say,
I was just about to say this. Mhm.
I think I'm going to harm someone, or even more
Uh-huh.
triggering for psychiatrists, psychologists is, I'm going to hurt myself,
Yep.
everybody freaks out.
Yes. Mhm.
If you can
Yep.
understand, and this takes, some experience, but if you can understand,
Yes.
I am having an obsession that I think I'm going to kill myself, right?
Mhm.
That is very different than having suicidal ideation.
Correct.
And it's two
Yep.
very different treatment plans. One is we have to
Yes.
make sure the kid is safe, which unfortunately sometimes means a hospital.
Right.
That would be a horrible thing to do for someone who's experiencing that kind of obsession.
Yes. Yep. I've had so many I was just about to say this because I've had so many kids sent to the ER, for quote unquote suicidal thoughts. And then when they actually come to see me and I take 10 minutes to break it down, it is not at all suicidal thoughts.
Yep.
It's obsessive thoughts about hurting themselves. And I think unfortunately, I don't know if people don't have time to piece that apart or they don't have experience or as soon as they hear the words hurt myself, they just panic and send kids
Yeah,
to
I think
the
it's
ER.
all of it. Yeah.
But but unfortunately, like it can be really traumatic going to the hospital for these kids. And it's not
100%.
therapeutic all the time,
No.
right? But taking the time to like really dissect those thoughts and when the kids are in your office just crying, sobbing because the thoughts are so distressing to them and they're scary, that's an obsessive thought. That is an intrusive obsessive thought. That is not like I'm depressed and I want to kill myself.
Yeah, so feeling scared, which we could, have a lot of words to describe that emotional state, is
Hmm.
reflects perhaps like an OCD thing is happening.
Yeah.
And a
Yep.
big piece of treatment in the beginning is you're educating, but then you're helping the child and the family start to help the kids separate themselves, like their true
Yep.
core self, from their
Yes.
OCD.
Hmm.
And that's kind of like a trippy thing to do, right? Because kids are like,
Yeah.
it's me.
Hmm.
And I think that's hard for adults to lean into as well. But
Yeah.
building awareness is one of the most powerful parts of treatment that the child starts to be
Hmm.
able to say, oh, that's my OCD. Oh, that was my
Yep.
OCD talking. Because once the parent can see it, once the kid can label it, then we have a different plan of action. And quite
Yeah.
frankly, clinicians have a different plan of action, right? If that's OCD, we
Hmm.
don't go to the hospital. Um,
Yep.
would be, a very specific example of that.
Yeah, yeah. I know. I feel like once my son was able, like he and his therapist, they use the word stuck thoughts,
Uh-huh.
kind of
Yeah.
like what you said, sticky. And once they were able to identify it, I feel like it changed everything.
Everything.
Like now, in the moment, we can be like, "Is that a stuck thought?" And he's able to like kind of think for a second, and say, "Yeah, that's a stuck thought." You
Hmm.
know. Um, and so but it's crazy. Like once been able to identify it, now we're seeing how often it's happening
Hmm.
that we just had no idea. We
Right.
had no idea.
Hmm. Yeah, thoughts are
It's wild.
interesting because you can think a lot of things and none of it be true or none of it
Mhm.
happen.
Mhm.
And that's actually a pretty new concept for a lot of human beings.
Mhm.
Um,
Yeah.
so I can, and it's interesting doing this work because when you talk about bizarre thought patterns, I mean, I have them all day sitting here with people,
Yeah.
and you can almost
Uh-huh.
make that playful for kids. You can say things like, okay, right now I'm going to take this glass of water and I'm going to pour it on my head. You ready?
Mhm.
Here I go.
Mhm.
I'm going to do it, you know, and I don't. And it's like, but I
Right.
thought it. I said I was going to do
Mhm.
it. I imagined myself doing it, but I did not.
Mhm.
And,
Mhm.
I mean, that's just a very small example. You can do silly things with kids, but helping them understand the relationship between how they think, what
Right.
they do. I mean, it's like the basic, psych stuff and how they feel, and that those things aren't always linear. I mean, just because
Right.
we think
Right.
it, we don't do it. Um, but people have a lot of shame around particular sets of thoughts. Like, how would I even come up with that?
Yeah. Yeah.
Am I
And
the
so I guess
kind of person?
that's kind of like teaching them that like they can have control over their response to the thoughts, right?
Yes. Although there's nuance there. So a big piece of
Yeah.
what we're doing with OCD treatment is we're trying to help them um, accept, lean into
Uh-huh.
uncertainty.
Okay.
Right? We don't know exactly what's going to happen all of the time.
Right.
Um, and so, to your point, yes, we are teaching them through exposures that even though they think something doesn't mean it's true.
Right.
But there's this very thin area you have to be careful with kids because when you're doing exposure, there are a lot of times like they're like, they'll want you to tell them that it's still going to be okay.
Yeah. Mhm.
So, I'm trying to think of a recent one. Okay, someone recently like was really upset by a piece of dirt on the bottom of their shoe. Well, this is a really hard
Okay.
obsession to have, and that's going to ruin my whole day. Everything's going to go wrong today.
Mhm. Mhm.
So the exposure there is to have some dirt on their shoe and
Mhm.
to exist. Well, even though they might do that, they might then start being like, well, is everything going to be okay? Is it
Mhm.
right? Like they want you to tell them, even though they're like engaged in the thing, that the bad thing's not going to happen.
Right.
So that can get sneaky to go back to that word.
Mhm. So what is like when you're coaching parents on how to, I guess, like get out of this OCD pattern of behavior that they're involved in, like
Mm-hmm.
what are the responses that you're teaching them when the kid is like having a reassurance seeking or compulsion?
Mm-hmm. I mean, first is what we just referenced is labeling it. So if we can
Uh-huh.
practice that in the office and develop a practice that at home and the kid's willing to accept the parent labeling it, which can cause
Mhm.
a lot of tension because kids can be like, it's not my stuck thought, it's not my OCD, you know? So
Yep.
there's that journey that parents are on, and that's not just a light switch. Um,
Mhm.
the other thing we coach them through is we have to do this in a gradual way.
Yeah.
So in therapy, part of my job as a clinician is to better understand the landscape of all the OCD. And then we
Mhm.
build what we call a hierarchy. Like what's the stuff that's
Okay.
a little bit hard, all the way to the stuff that's like really, really hard. And we start with the little
Yeah.
stuff, right? To build
Mhm.
confidence and to quite literally teach the brain, like, oh, it can feel better even if you don't do this thing, even if the parent doesn't do
Okay.
a particular accommodating behavior. And so part of the coaching for parents is parents can go one of two ways. Some are like gung ho and they're like, I'm not doing anything anymore. And I mean, they're going to have a
Mhm.
horrible week, you know.
Yeah.
And then some parents are like, I'm not going to stop any of it. But part of
Yeah.
what you're collaborating on is like, what are small things we can start to do?
Okay.
And helping them make those decisions. Like we do that
Mhm.
collaboratively in treatment of like, this week, we're going to practice this and kind of
Yeah.
taking the pressure off that everything has to change all at once. Um,
Mhm.
and just like we're teaching kids to tolerate their own distress, we're really having to teach parents that too. We're having
Yeah.
to teach parents to tolerate the kids' distress, but also their
Mhm.
own, because it makes a
Yeah.
parent so upset to see their child
Mhm.
suffer.
Yep.
And so we really have to work with parents of like, okay, when you don't go in there to wipe them, for the third, fourth time, they're going to cry
Mhm.
and they're going to be really upset.
Mhm.
And we have to remind ourselves that we're doing this to help them get better. And you have to
Yeah.
kind of have parents almost have a script for themselves, some grounding statements, some
Mhm.
things that ways they can help themselves get through those moments because
Yeah.
it's truly
Yeah.
really really hard. Um,
Yeah.
and if it was easy as just telling parents not to do it, I always tell families I wouldn't have a job. I mean, like,
There you go.
that's why I have a job. It's hard. It's really,
Yeah.
really hard not to do it. And, I always tell families and parents that they're the expert on their family.
Yep.
And so part of it too is parents coming back to me and saying, this is how this exposure went. It was really, really hard. It ruined the
Mhm.
whole day. And then
Yep.
part of what we work on and where I guide them is like, maybe we pushed it too far, or maybe we need to
Mhm.
dial back a little bit.
Yeah.
And so I always invite that feedback from parents because I really don't see myself as like the person in charge, like
Right.
I might give recommendations and they work or they don't, and we have to kind of fine tune things.
Yeah. Yeah. So you're a guide that has a lot of experience, right? I mean,
Right.
that's kind of how I feel about my job too. It's like, I don't have a crystal ball. I don't know 100% of the time what's
Hmm.
going to work for every kid, but I at least have my clinical experience and then my education to
Hmm.
help me guide. And then it's like collaborating with the family.
Yes. Yeah. And I think that's That's takes a lot of growth as a clinician. I wasn't as good at that in my
Yes.
initial years because you kind of think like,
Uh-huh.
I have the answer for you. And then as you parent yourself, I mean, I think that's been very impactful
Mhm.
for me because, I'm in the middle of
Yep.
parenting. And as you work
Mhm.
with more families, you just remember that it's messy. You remember
Mhm.
that people are all very different and people want their
Yep.
autonomy. And so that's
Yep.
something that I really try to honor as I work with families.
Yeah, absolutely. Well, Courtney, thank you so much
Of
for
course.
coming on. Any imparting wisdom you want to give to parents who have a kid that has OCD?
Oh goodness. I think I offer, a lot of empathy to those families
Mhm.
because it truly is hard and causes
Yeah.
suffering and it's quite an emotional burden. Um, I also, it might sound kind of cheesy or cliche, but I always remind parents it's not their fault because that's true.
Mhm.
And
Yep.
I think that when you learn about treatment, that sometimes parents, because we're asking parents to change their behavior, the way they
Mhm.
interpret that is, oh, I've been doing all this stuff and that's why my kid is like this.
Right.
And
Right.
it's like,
Mhm.
no, this is the nature of the beast. If your child
Yeah.
has OCD, you have to be part of it. And so while it's not your fault, I really want you to feel empowered that you're part of the agent of change.
Yeah.
Um, So yeah, and then I would say like just I often recommend this resource to families in terms of getting support
Okay.
outside of the therapy office is the International OCD Foundation. So that's
Mhm.
IOCDF. And if you're gonna get online, I think it's a great place to get information. And also,
Yeah.
increasingly, there's a lot of support options, like parent support groups that are virtual or talks parents can listen to, or even conferences you can go to. So therapy is seeking support, but also encouraging, finding support in other ways, just to help that
Yep.
feeling of like the loneliness involved in parenting a kid who's suffering with OCD.
Absolutely. Absolutely.
Yeah.
Okay, well, this was all super, super helpful. Thank
Good.
you so
Of
much.
course.
Parents, if y'all have a kid that has OCD or you know a kid that has OCD, go check out that website. And feel free to, DM me with any questions about it. All right. Thanks, Courtney.
Of course.
Thank you for tuning in to this episode of the Little Brain Campaign podcast. If you enjoyed our conversation, give us a follow on your favorite podcast platform so you never miss an episode. Please take a moment to leave a review while you're still thinking about it. It really helps grow the podcast, and I love hearing from our listeners. See you next time.